So I want to introduce Dr. Luke Messick. He's an emergency medicine physician, local props, completed his residency at Rhode Island Hospital, currently practicing at Brigham and Women's Hospital in Boston, and is an instructor at Harvard. He's also a historian focusing on the history and political economy of healthcare. He has an upcoming book called Your Money or Your Life, Debt Collection in American Medicine, which should be out next month, I think. That's what we're doing. Okay, great. Thank you.
Maybe you want to take one at a time? Okay. All right. Yeah, thanks so much for having me. I'm really excited about what DSA's done, what DSA is doing. Really grateful you guys have come to this event, along with PNHP, where I've been a member for a long time. Physicians Information Health Program pushing for a single payer system. And I guess that's where I want to start, because this movie makes some great points and features people who I really admire. But I will say that the focus on hospitals is interesting and necessary, but it paints a picture of like Maryland is this like utopia where, part of my book is about how Johns Hopkins Hospital in Baltimore, Maryland continued to sue patients, many of whom were its low-income workers, over unpaid medical debts long after this all-payer system was put in place. It's pretty irrational to think about it, because they don't actually make that much more money from doing so given the all-payer system, but they continue to do so. So there's just a lot of cruelty in our system and money-making that lies far outside the realm of this movie's purview. And really the only answer to the system that creates medical debt is to stop the flow of medical debt. And the way that happens is through a tax-financed single-payer healthcare system. So with that grand vision in mind, then I just want to make, just one more point before I want to hear from Claire and Michael, because I'm really excited to hear what they have to say too. But I would make a plea for proximity to suffering, which is to say that there's one patient in this movie, and her story is horrific, and it is not at all unusual. And if we just acquaint ourselves with suffering in our own community, then we'll find the same goddamn thing. I walked into Kent County Courthouse 4 years ago when I was a resident at Rhode Island Hospital, and found that my hospital was suing patients by the hundreds who could not afford their care. These were single mothers, they were recent immigrants, they were old folks living on Social Security disability, and they wrote the most plaintive letters you can imagine to the hospital, begging for some level of leniency, and they received none, aside from an offer to set up a payment plan that had them paying back a hospital bill for 7 years. So some of those bills are still being paid back right now. And if DSA wants to do something about medical debt, I know you guys are doing some great stuff right now, but those folks are still paying back those bills. They should not be paying for hospital care that was incurred 7 years before. They shouldn't be paying at all, but they certainly shouldn't be paying years later. So really forcing our hospital systems, if we want to focus there, on forgiving those debts and not forcing those kinds of payment plans on patients should be a clear focus. So thanks again for doing this.
So I'm going to introduce Dr. Michael Fine, writer, community organizer, family physician. He's the chief health strategist for the city of Central Falls, and well known as the former director of the Rhode Island Department of Health. Currently the board vice chair and co-founder of the Situate Health Alliance, which I am familiar with. Among other titles, both fiction and nonfiction, Dr. Fine is the author of Healthcare Revolt, and his newest book is Medicine as Colonialism.
Thank you. Thank you all for being here. Thank you all for being here. I've gotten to spend a lot of time in healthcare in my life. 4 of the people you saw are close personal friends. One of them I was talking to yesterday. And I've been on the board of the Lime Foundation for 100 years. And I've had opportunities to spend time with people all across the healthcare system. I sort of feel like Hunter S. Thompson. Some of you are old enough to remember Fear and Loathing in Las Vegas. But Hunter S. Thompson was supposed to give a big lecture, I think at the University of Michigan or something like that, where there were like, a big football stadium, there were 100,000 people. Thompson was 2 hours late. And after, people being totally frustrated, he stumbled out completely intoxicated and said, "Yep, it's all true. All that party, all those drugs. Any questions?" That's kind of where we're at. This is all true and worse. I can detail who owns hospitals, that the hospitals are already public institutions with no public oversight. 60 to 70% of all hospital income is from public money, and yet hospital boards are privately appointed with no oversight. Much of what happens in hospitals is an artifact of the fact that we don't have a healthcare system that's for people, not for profit, and provides primary care in every neighborhood and community, which is what we need, because that's what successful countries do. We've known this data for 40 years. This is not new stuff. So at the end of the day, what we have is not a problem in healthcare. What we have is not a problem with what purports to be a healthcare system, but is really a marketplace and a wealth extraction system. That's not the problem. What we have is a political problem that for some reason, which I only partially understand, we have been willing to tolerate. It runs because $718 million a year is spent on lobbying. But until we organize, neighborhood by neighborhood, community by community, and resist, it will continue.
And thank you, Dr. Fine. I'm going to introduce Claire Zeller, who is co-chair of the Rhode Island chapter of DSA, Democratic Socialists of America.
Hi everyone, thank you so much for coming. Thank you to the Medicare for All Committee for organizing the event and to PHP for sponsoring. So I don't work in Medicare, but I am here to represent the perspective of Rhode Island DSA and the perspective of the socialists living in America, who I'm sure, like many people in this room, has had negative experiences with the healthcare system. So I think that the documentary identified, correctly that our healthcare system is in crisis. But the solutions that they offered, like changing economic incentives, and changing economic incentives doesn't quite get to the root of the problem. That might be a good short-term solution to kind of give people some relief. But ultimately, the problem is that, like Dr. Fine said, we don't have a healthcare system, we have a healthcare market. No aspect of healthcare should be for profit, be a single-payer healthcare system. And I thought this was funny. The documentary talked about setting price controls so that people are paying a reasonable price for medical procedures. I think that at the point of care, a reasonable price for a medical procedure is $0. And I think the other two kind of touched on this, but I think our current political system has proven that it is not going to pass Medicare for all out of the goodness of their hearts. The only way that we are going to achieve an equitable healthcare system that actually cares about keeping people healthy and saving their lives, which is a human right, is by a mass mobilization of the working class coming together to demand it.
So we'd like to open it up for discussion. Are there any questions or comments?
Yeah, hi, my name is Pat. I caught most of the video, wonderful video. I just wondered, what was missing was a conversation about executive salaries. We've got a situation here in Rhode Island where, members of the staff of hospitals, and I'm talking about the people who do the linen, the CNAs, are barely subsistence living, working 2 jobs as medical professionals, and yet you've got CEOs making millions in, air quotes, not-for-profit organizations. Just wondering what your thoughts are.
So the numbers are pretty clear. Of the 85 largest hospital systems in the United States, only 5 in 2017 were paying their CEOs less than $1 million a year. 13 were paying their hospitals between $5 and $23 million a year. And there have been some stories in the press about recent hospital salaries in the 30s and 40s of millions of dollars a year. These are not-for-profit, technically, though not-for-profit, when you get to hospitals, means not taxable, because the profit comes out as salaries for senior executives. 20% of all hospital revenue goes to pay employees who are making more than $100,000 a year, even though 50% of hospital employees make under $50,000 a year. This is all public money. The problem isn't that it's happening, though that's a huge problem. The problem is that it's happening in plain sight, and we let it happen instead of doing something to change it. I don't get why we haven't made it so that every single hospital board member is elected. How can we, and that hospital board members and C-suites have to look like the communities that they serve. What you have is hospital executives who, serve or work in hospitals that serve poor and working communities and live in Barrington or East Greenwich. This happens, there's this just wealth extraction where Medicare and Medicaid are basically used as a way to suck money out of communities, the communities that need it, take away their agency in the process, and then the money goes to investors and high salaried employees. But the problem, again, isn't that it's happening, because we know it's happening. The problem is that we haven't organized to change it.
So all of you, several of the people in the room, have tried to speak to audiences of medical people, non-medical people, and political people. What have you found to be effective ways of communicating this message to groups of people? What messages seem to resonate most with the communities you've addressed?
I guess for me talking to people sort of on the political level, I guess I tried to connect it to personal experiences that they might have had. I think that it's a very well-known problem, the crisis that our healthcare system is in.
But probably not well understood.
No, probably not well understood, but I think that everybody, understands that, they are not getting the quality of care that they deserve or expect, and that they are being charged way too much. They might not even go to the doctor because of how much it costs. There was a whole thing with, I'm reminded of Obama saying, if you like your private insurance, you can keep it. And I'm like, who likes their private insurance? Seriously. So I think that it's a near universal problem, because everybody at some point in their life is going to need healthcare. And so inevitably you run up against those problems. So I start to do this personal experiences.
Well, you've talked to more audiences than, I don't know, you and Michael, I don't know, but you guys have talked to people for years. What do you think works?
Well, if I knew what worked, we wouldn't be sitting here tonight.
Or we'd be sitting here with 1,000 of
That's right. We'd be sitting here with 1 million people. That's the population of the state.
Yeah.
I don't know. The problem, the way I perceive the problem, is we have a few well-meaning people who understand what the problem is, who understand potential solutions, but we have an extremely well-financed counter message that seeks to distract, to direct people's attention to things that are not actually the problem, but are somehow could be affiliated with them. One of the people running for Congress introduced themselves as being the protege of a dynamic young governor of Rhode Island, and when I pointed out that that dynamic young governor had cut Medicaid funding twice in her term, which helped to force the closure of Memorial Hospital in the town where this person grew up, this person seemed appalled that I would bring this up. So it's, I think we understand that there's a problem, and the people we talk to understand there's a problem. It's difficult to communicate how you fix it and how that can be done. And one of the people, there was a name mentioned in one of the things on the film, Ezekiel Emanuel. He used to be an oncologist. Now he works for the American Centers for Progress, which he actually came to the Watson Institute Brown a few years ago. And while he was addressing us, as certain troublemakers sitting here with a hat in his head, actually Googled who funds his institute, and which he did not bother to mention. And Jim found out that actually the American Center for Progress was largely funded by insurance companies. And Ezekiel Emanuel's point was that, well, of course, a single payer system would be great, but it's impossible because we can't beat the insurance companies. And you have well-educated people saying things like that. It makes all of our jobs that much more difficult.
So, go ahead.
Oh,
And well, I was just getting an answer to your question. As you may know, I went off to write fiction at a certain point because I couldn't stand it. and that was part of it. And part of it was because I thought this was basically a problem of imagination. But recently, I think it's starting to turn. And the language that seems to get people riled up is very simple. We need a healthcare system that's for people, not for profit, and starts by providing primary care to every American, in every American neighborhood and community. Something that's palatable. Part of that is set up because we have a primary care disaster and no workforce. And I think part of it is that people are just done with for-profit health. But there is language. The other thing that I've been saying is it's time to stop admiring the problem and start to change it, which means inviting 5 people into your kitchen or your living room and start to talk about how you can make a little healthcare system in your own community that's for people, not for profit. And I get to talk about Scituate, Rhode Island, which not everybody knows is the only place in the United States where everybody's guaranteed access to primary medical and dental care. It's the most Republican town in Rhode Island, and yet it's been like that for 20 years.
can I just respond really quick or add something? So in terms of how we convince people that we're able to fix it, I think one of the issues is not that people are incapable of understanding the problem or that they're even unaware of the problem, because most working people are experiencing the failures of our economic system every single day of their lives. But the issue is that a lot of working people just don't have time or energy to become politically engaged and to fight for something like a single-payer healthcare system. So part of the work of winning Medicare for All is engaging those non-political, those people who previously haven't been engaged in politics, helping them realize that their lives actually are political, and offering them an alternative to the current sort of political pathways that are offered. Right now we're told that all we can do is go to the ballot box and vote for two people who aren't going to change anything. But if we offer them alternatives for actually building power in their communities and not just relying on voting every 2 or 4 years, then I think that can start to help people feel more empowered and like they can take things in their own hands.
Yeah, I mean, we're already kind of there, so I was going to ask more about mass mobilization, and more like specifically like thoughts on starting a working class political party. maybe not what that would look like, but what would the beginning stages of like building real political power outside the acceptable system, because it's like, as Dr. keeps saying, we know the problem, and it's actually kind of mind-boggling to me that like, we're talking about like CEOs and exec and people like that, capitalists who are just like knowingly killing people, and we're just like talking about price controls. Like, why aren't we sending these people to jail or shooting them? Seriously, but yeah, if we can talk more about mass mobilization and political power via third party, please.
Yeah, I'm still going to focus on nonviolence, but I think we haven't even started to try, really. I mean, we like, it's really inspiring to see folks who've done things locally and making, Situate a place where people can have access to primary medical and dental care. As a matter of course, is really inspiring, but like for those of us who haven't done something like that, like I think we've got a long way to go. And the people I actually take a lot of inspiration from are union organizers. I just finished writing a history of medical debt in the United States, and like the people who've done the most on this, they're not doctors, they're definitely not doctors. They're usually nursing and food service workers at local hospitals through their unions, organizing for patients and for themselves, frankly, because they are some of the people who are being sued by the hospitals to organize to get a more decent healthcare system. At Yale, it was food service workers in 2004 who were pushing the hospital system to stop suing patients. And Hopkins, it was nursing unions doing the same thing. And so, working class mobilization is the answer. And the more we can do to support those efforts to draw attention to specific outrages and make sure that unions have our full support in organizing their members to push large, powerful entities like hospitals to do better, then the better off we'll be.
Sure, just
Yes.
no, why don't we go to the next question?
Okay, so I was just talking to Claire and Dr. Fine, so you don't take this personal, because I actually admire Dr. Fine. I actually followed his career for quite a while. One of the things that I saw is we have a lot of people here. No one seems to invite any of the politicians, and if you don't invite them, they can't hear anything. Because they didn't even have the opportunity to show up, because they didn't even know the event came. Put that aside for a second. I'm a person that knows that nothing can be run without money. No matter how much you love it to be free, it can't happen. That said, there are ways to make it where it is, because like, I just had an injury with my leg. I had an infection in my leg, which I didn't pay the medical coverage for many weeks after I left work, because I wasn't able to make a pay at any sort, so I couldn't make my payments. So there should be some type of gaps, and as like I just said to Dr. Feynman, and he said he didn't look at it this way, which was, if we all have the right for counsel, if we went in front of a judge, we should also have the right to have doctors, being American citizens in this country, for when we either lack or are falling shy of medical coverage of some sort. And that would balance it out, because again, we don't love things for free, but it just doesn't work in this world. So there is a way to make that balance, but nobody really looking at the balance. They're looking at left or right. If we look at the balance, we'd actually have more of an argument. And I don't see the argument being thrown out, even though that there is one to be said. Because there's many weeks and months that I paid medical coverage that I never called the doctor once. But for when I called the doctor, they ran from me because I couldn't work that week. Go ahead.
So can I take a shot at that? I don't think we have a problem with health insurance. I think the problem is health insurance.
I agree with that.
You know, primary care is an essential service. You know, everybody needs it. And it's what we use to prevent illness, preventable illness and death. We actually have the tools to eliminate colon cancer. We had the tools to eliminate HIV/AIDS in 1997, only we didn't have a healthcare system that let us put those tools to work. All you have to do is test everybody 13 to 64, find everybody who's positive, get everybody who's positive on treatment, and then for HIV, treatment is prevention. You don't transmit the disease once you're on treatment. The disease goes away because we don't have a healthcare system. We lost over 500,000 lives. And yet primary care, it turns out, is effectively, you know, I like to say cheaper than water. It's not quite as cheap as water. But, you know, the cost of primary care is $500 per person per year, roughly. Per person per year. Out of an expenditure for health insurance of now about $14,000 per person per year. The cost of primary care is like the cost of roads and the cost of police and fire protection, and way less than the cost of education, even measured per person per population, not per person per student. We can afford to give it away. You know, and not only can we afford to give it away, that we don't give it away means we're spending $2 trillion a year that we don't need to spend, and that's money that we ought to be spending on education and housing and public transportation and the environment, which turn out to be the things that matter for health. So, you know, is it free? Can we make it free? In fact, if we don't make at least the primary care part free, it's costing us arms and legs, literally.
Can I just say also, wouldn't it be nice if we had a system that wasn't tied to employment, where it didn't matter if you were out of work with an injury and you just had health insurance? It just wouldn't be an issue.
In reality, Dr. Fine is the patient, and I love to live in a house, and therefore, to sit there and say that for the person that can afford it, should afford it, so he has a job, he studied it, he should get a paycheck. I'm not against that, but at the same time, if you have a system that actually covers both the working and the non-working, it actually could balance it out if everybody looked at the whole picture. Instead of just one side or the other, you can balance it and say, there's so much covering on this side. If we cover it 50-50, we could cover the ones that are not insured and the ones that are insured, if we can figure that dynamic out.
So,
And I see one person looking one way or one person looking the other. No one balance it too much.
so I just want to make one more comment and then I'll take the next question. For years, we've actually had systems that would fill in those gaps, like COBRA, which was like, what, $700-800 a month for somebody who was out of work for a short period of time, who was not getting a paycheck. And then we had Affordable Care Act, so if you were out of work, you could then purchase your insurance, which over the years, the insurance became crappier and crappier and less affordable. So we are looking at something that will balance everything, that will cover everything. Everybody's insured. It has nothing to do with whether your employer can afford the crazy premiums, whether you lose your job because of COVID, you're just covered. Other countries do this. It's not rocket science. We are the only country that, you know, Western industrialized, whatever country, that doesn't do it for its citizens. And believe me, nobody's talking about healthcare providers working for free. I don't want to work for free.
Correct.
But the money's there. It's just not going to healthcare. It's not that there's no money for it. It's getting taken in profit.
I want to make 2 points. One is about insurance and the second is about hospital boards. And I just, by way of introduction, I worked in the health system that was mentioned in this film in the Lehigh Valley that had $2 billion in reserves sitting there doing nothing. And the second is that I work for Aetna, the health insurer. So my first point is about health insurance. And a lot of this discussion it doesn't really reach the root of the problem, which Dr. Fine mentioned, which the problem is not about health insurance, it is health insurance. And there's a reason for that, which I want to share with you because I think it'll help solidify your opposition to the current system. And that is that there are two kinds of insurance. The first kind of insurance is property and casualty insurance. And that relates to things like houses, cars, let's leave it at that, but boats and so on. If you're a wealthy person, you have an expensive house, and you have to buy expensive health insurance. But you have enough income to pay for that, okay? The same thing with auto insurance. If you're wealthy, you have a big car, expensive car, and you can afford the insurance on it. But if you don't have a car, or you don't have a house, or you have a small car and a small house, then you buy that because you have a small income, and you can afford to pay the insurance on that. So think of that as being that the risk, if you have a big house, your risk is a big loss, but you have a big income. On a small house, you have a small loss and a small income to pay the premiums. But when you think about healthcare, everybody has a body. We all have the same risk of getting sick, and that has nothing to do with how much money you make. So the way you ensure that is you say, okay, as a society, as we've heard in this film, and our panelists have said, then being healthy is a public good. It's not a private good to you. If you're healthy, you can work, you increase the productivity of the country, you pay taxes and so on. So it's in our interest to have everybody healthy. And the way you do that with insurance is with social insurance, which is what Medicare and Medicare is to some extent. And that is based on the idea that each person pays in what they can afford to pay. And if they're not working, then they don't pay anything. But when they are working, they pay something. And if they have a lot of money, they pay a lot. And then, when you get sick, you get the care that you need because the money is there. You don't get what you've paid for, which is the current system of health insurance, because we insure health in the same way that we insure a house or a car. And that is wrong. The way that we should insure people is on the basis of three things. You pay what you can at the time that you can pay it. You get what you need at the time that you need it, and it's free at the point of care. That is the system that we need to have. And all this, the stuff that we're talking about this evening is all driven by the fact that the US healthcare system has a category error in the way that it's set up. It should be set up as social insurance, not property and casualty insurance, because human beings are not property and casualty. That's my point. I have a second point that I just want to share, and that is about hospitals, because I worked at one of these hospitals in the Lehigh Valley. And there are two kinds of hospital board structures. The first is where the hospital board basically self-perpetuating. They have a little committee to find new board members, and the CEO of the hospital invariably sits on that little committee of 3 people. And what does he or she do? They pick, in my opinion, they pick some of the dumbest people in the community because then they can do what they want, which is what we've seen in this film here. The second kind of hospital is a hospital where the board members are elected by what are called members of the community. And anybody can pay, a few dollars and be a member of the hospital. And if you're a member of the hospital, you can vote for who goes on the board. Now just imagine if rather than the board being selected by the CEO, that the board was selected by the community, by people like us. All of this would change because then you could hold the board accountable to fulfill the mission of the hospital, and you could point out to the board all the things that we hear that hospitals are doing wrong, not for the community but for the CEO, and that people will not sit on the board and be ridiculed in the way that this would happen if they were dependent upon the community rather than the CEO for their position on the board. Thank you.
So what you were saying about comparing health insurance to other kinds of insurance, I think this speaks to the history
This country did not, most people did not, and most businesses did not have health insurance prior to World War II. During World War II, we had a wage freeze. So, wages froze, and companies wanted to scale employees. How do you take an employee? You offer them benefits. So benefits became an essential part of the American job. But before this creates a really big statistical trend that healthcare used to be affordable. Now, if you look at states where you have to get car insurance, which states which you don't, car insurance is a completely different price. You can pay $40 a month in a state where your car insurance is not required by law, or you can go to Rhode Island and pay $200 a month. But for the body, they did the same thing. Corporate found a way to make it so we need health insurance by offering different prices to people, to the insurance companies than they are to people. Insurance used to be non-essential. Even if the system changed in the simple way of we can pay what the insurance companies negotiate for, it can be directly affordable because we used to have a system where that was the case. We have this like level of inflation where we can actually compare it to other kinds of insurance. That's the goal of insurance companies, is they want to make their thing an essential service and then raise the price. It's a lot easier for the body because we all need to live.
Also, I think something important to note is that having your insurance tied to your employer and your, having a job essentially is very advantageous for employers because it gives them a lot of leverage over their employees. If a worker, say, wants to try to fight for better working conditions or higher pay, they can start to take it away. But also these different tiers that end up getting offered to people through their employer-provided insurance divides the working class because there are people who are uninsured, there are people who have very little coverage, and there are people who have pretty decent coverage. And the people who have good coverage might look at a campaign like Medicare for All and say, well, I'm okay, I'm fine, so why do I need to fight for this? And I think it puts fissures in the working class and it gets people to resent each other and not understand each other's struggles.
One tiny little bit of history about insurance that most of us forget is that insurance really originated in the 1870s through the 1920s. And insurance actually were groups of people who came together to take care of each other. And it got co-opted. And that's the point. The point to me is this is a political problem. We can organize ourselves to do good things for each other, but we got to keep our eyes on the ball and not let the greedy folks, the people who don't mind profiting on someone else's misfortune, to work their way in.
I was going to ask Dr. Messick, really quickly, since you have a book coming out called Report on death, on medical death itself. And that is also the campaign that Rhode Island DSA has chosen to take up over the next couple of years. Since you've seen this and you've talked about it briefly, I was hoping you could open up and maybe make that more vivid to this group. What are people really going through? What have you seen? And maybe you can walk through what the experience of medical debt and how that changes people's lives.
Yeah, sure. I mean, so let's focus on what hospitals do to people in medical debt. So you have a medical bill, you cannot pay it. 120 days after that bill is issued, it's open season on you. They can do all number of things. So they can sell your debt to a third party, they can assign it to a third party. Those folks are particularly aggressive in pursuing debt, which means taking you to court, garnishing your wages, seizing your bank account. If you don't show up for the post-judgment action to decide how much money you have in your bank account to seize, they can put you in jail. So these are the panoply of legal, extraordinary collection actions that hospitals can take and do take if you don't pay up. And there's supposed to be there's some provisions in the law in the Affordable Care Act that say that hospitals are supposed to take reasonable efforts to determine whether you are low income and therefore shouldn't be subject to these actions. But that doesn't mean anything. All that means is that they have to send you a mailing saying that hospital financial assistance might be available to you if you can get yourself together and apply for it and the hospital chooses to give it to you. So, some states have really put a limit on what hospitals can do, what kinds of legal actions they can take, and how much legal jeopardy they can put you in. And actually, Maryland is one of them. So they didn't even talk about this, but like, due to concerted action by unions and by community members, there were 2 bills passed, 2020 and 2021, that limit the lawsuits that hospitals can put on you. They prohibit the sale of debt. They prohibit arrests from happening. I mean, people are being literally put in jail arising from medical debt, right? So there are states that do better. Do you know how Rhode Island ranks on the list of medical debt protections in the country? 150, 46. So, you know, we have a terrible, terrible slew of state protections because we don't have any state protections. And we could do a whole lot better. So, you know, I really am grateful that DSA has taken on this issue of medical debt. And, you know, one of the ways that some groups have tried to do this is by purchasing medical debt and forgiving it. And I know that's one of the things on the table. That is undeniably helpful to the people whose debt is being forgiven. But it lines the pockets of debt collectors themselves and hospitals who should be doing better and not just pocketing money. So, you know, I've talked to RIP Medical Debt and people who've been doing this work for like 10 years, and they convinced John Oliver to do that big giveaway in 2016. And it is feel-good stuff, and it definitely helps the people whose debt is forgiven, so I'm not going to gainsay it too much. But I think that focusing on the things that hospitals can do to make their patients' lives easier, or at least not put them in legal jeopardy, should be a clear focus of any campaign.
What's the percentage?
Oh yeah, Dr. Fine was asking about personal bankruptcies related to medical debt, which is like this whole issue in the literature, and people argue about back and forth, but it is the #1 cause of personal bankruptcy in the United States. Probably the majority of personal bankruptcies have, you know, medical debt as a primary cause of them. So like I'm glad you guys are taking this on. Yeah.
66% in 2016.
Thank you.
And how many other countries, how many other industrialized countries, does anyone have any medical debt?
Yeah, I mean, it's laughable. Like, people, I mean, you see all these videos on YouTube where they ask like French people like how much medical debt should cost, or how much medical bills Americans have, and they can never guess the right number. They always guess like 2 orders of magnitude too low.
So I think that and as a member of Rhode Island DSA, Medicare for All is a really interesting issue for us because on the one hand, you have a very clear problem that is very well known among people, and you have a solution that's extremely popular. I mean, Medicare for All, free medical service at the point of access, is one of the most popular polling policies in the country. But there's a question, which is, there's this misalignment between where we're at and where almost everybody in the country wants to be at. And there's the problem of making it stick when we get to that place. I'm thinking of things like the NHS, other universal healthcare programs in Europe that were really great and were, put in when there was a lot of Marshall Plan money flowing around. But as profits got tighter, as money became harder to make for capitalists, they've been chipped away at and chipped away at it. So I guess my question would be, one, what is the path from where we're at to implementing an incredibly popular position? And two, once we have it, or in the process of gaining it, how do we make sure that it sticks?
Well, maybe I'll answer your second question first. I think the answer to making it stick is that once we win Medicare for All, we don't stop there. We come for every other for-profit industry, and we come for democratic control of the entire economy. Because any other structure, exactly, these reforms, even though they will be massive wins for the working class, will be constantly under threat of rollbacks and of being gutted because of the strength of lobbies, in our political system. And your first question was on how do we get there? That's a great question. Yeah, do you wanna jump in?
Just to jump in, yeah, I mean, I think that my interest in this came through global health. Like I worked in Malawi, I worked in Rwanda. I wanted to be a doctor, not so I could practice in the United States because the system makes me want to cry every day. But I realized that we are exporting the system. Like we are poisoning the well of healthcare everywhere else in the world. You know, I read USAID reports that insist on inserting user fees into places that don't have them, and just making healthcare into a commodity where it had no right. And there's this book about McKinsey, and one of the chapters is about how they were hired by the Tory government in the UK, and every single slideshow they ever put up for the Tory government was, you know, the Americans do this, the Americans do that, we can make the NHS into America. Can you imagine a more disgusting slideshow than to take the NHS and to turn it into what we have right now? Like, that's what they're working on. That's what we're exporting. So if we fix our house, then we will at least stop being a virus in the entire world. So I really do think that adequately funded single-payer healthcare systems are going to be a challenge until America stops, telling people to stop doing that.
Could I just say that I worked in the NHS at the time that this was going on, and you're absolutely right. And I saw it then as being the exporting of neoliberalism, and healthcare was just one part of this business of privatization. I agree with you totally in what you said. Thank you.
So I have a somewhat different spin on strategy. The first strategy, I think, is for everybody in this room to swear off using the word healthcare system, because we do not have a healthcare system in the United States. To whenever we speak about this healthcare thing, call it a market, because that's what it is. We gotta start telling the truth. And there are opportunities to come up all day long, seize them. Now, that said, I'm part of a new organization called Primary Care for All Americans that aims to build a healthcare system that's for people, not for profit, and focuses on services, not insurance or not payment, and is going to attempt to do neighborhood by neighborhood, community by community organizing to replicate some of what we did in Situate and what have been done in other places, but do it, like I said, neighborhood by neighborhood and community by community. We'll see if it works. But if it works, the neighborhood by neighborhood, community by community strategy is, I think, the way to maintain the gains. Because when the board of the hospital, and even more than that, the board of the health center is elected by the community the way school boards are elected, where we evolve a world in which every community has ownership over its own health care and stays connected. That's a way to do two things. First of all, it's a way to get a healthcare system that's for people, not for profit. And the other thing is it's a way to bring democracy back. So if anybody has any interest in their strategy, either drop me their email address, or I have cards that I can give out. Send us an email and we'll get you involved. This is probably going to kick off in the next 3 or 4 weeks.
I just want to make one quick comment. So I think for how we get there, we have an idea of what we need to achieve along the way, or like what our goals are along the way. It's just a question of how exactly are we going to, what is the sort of day-to-day strategy that we're going to take? What's our messaging going to look like? It certainly involves going out and talking to people, like, citizens of Rhode Island. One of our goals is raising class consciousness, so helping working people to realize the immense power that they hold in their hands to change things, and identifying, the enemies of this current economic system, and also bringing working people and communities together. How exactly that's done? If you want to, if you have an idea and you know wants to give some input, or if you want to help us figure it out, the Medicare for All Committee will meet next Thursday at 7 p.m. So definitely, as we take on our medical debt relief campaign, you can be part of the process of figuring out how, you know, what it looks like to get there.
If you need help getting involved with DSA, come talk to us after.
Yes.
So I think we just have time for a couple more questions.
Just have one quick point, as a counterpoint. I've heard throughout the evenings, sprinkled throughout the evening, references to political change. Single biggest obstacle that the DSA faces here in Rhode Island in terms of gaining the political power, at least some leverage necessary to introduce arguments like this into the political sphere, which is where they unfortunately live, is the two-party rule in this state. I can tell you, I'm on the National Board of Directors of a political organization that is not the DSA. Rhode Island has amongst the worst ballot access laws in America. And I will put the challenge out to you because I've started a conversation with our Secretary of State to significantly reform so that organizations like Working Families Parties, DSA, the Communist Party, the Libertarian Party, the Green Party, all have a fair shot of having an equal playing field. And that's the change that needs to happen, because until then, there's an entire population that sees legitimacy only in the quote-unquote two-party system, the duopoly. And we all know, I think we can all agree, regardless of our background, how failed the duopoly is on virtually every level. I just want to throw that out there. So I invite you to join me.
Sure, and the DSA's electoral committee, we have recently decided to take the direction of looking past the two-party system, figuring out a strategy for possibly running an independent campaign and, you know, towards the goal of an independent first party. So if you're interested in that, you can also talk to that table over there.
So my question for the panel is about organizing in hospitals and medical organizations. So just based on your personal experiences in Rhode Island, what's your take on the ability, the availability, how feasible it is to organize from the ground up in the medical organizations themselves?
Sure. Yeah, I mean, this is something I did too little of, and I'm grateful for Mark and Linda, Senator Giuffre, for helping me into when I came to Rhode Island with Physicians for a National Health Program. So that's definitely one path of, specifically of physicians working towards a single payer healthcare system, which, we can always use more people doing. But I do think that union organizations within hospitals are like a key and, still untapped resource in this fight. And every example I've ever come across of real change happening had to involve them. And so I really do think that will be a huge part of it. Union organizing within hospitals is taking off. Residents in particular, I was one a few years ago, have started to organize in ways they never had before, forming unions. So this is a part of American life that medicine has finally come around to at long last. And I think if we can harness that, that would be a tremendous change.
Somebody who came very close to getting myself fired in residency, and a couple of other times, for doing organizing work. I think it's really important. I mean, it's doable, but it's hard and scary because, hospital administrators have on their desks how to keep people, books about how to keep people from organizing. But I just don't think there's any choice. We didn't come to patient care to make money or to profit off somebody else's misfortune. We came to patient care to be with people when they're suffering, to be with communities. And if somebody's going to get in the way of that, we need to organize ourselves and push them out of the way.
Democrat. And I would say that I've been introducing legislation that I think everybody in this room would agree is necessary, including going after the middlemen, pharmacy benefit managers, also resolutions in support of single payer. And I just want to also say that I appreciate this dialogue, and I hope we can all work together on all sorts of different fronts. And I welcome any comments or opportunities to discuss options to run for office. So thanks.
I got a issue. So, yeah, real fast. So, I had long COVID. And what a lot of the things that you all talk about is the medical care, and I get that. I was a single full-time father of my 2 children that were minors. Having full COVID, I can't work. I not only had full COVID and couldn't cover my medical, I lost my house, and then eventually lost my children. So it's not just the medical, but the whole structure because of mental illness of after losing your job, losing your medical, being, I think I had like 6 or 7 heart failures, and then on top of it all, losing the custody of my children, not because I'm not able to, but because I just don't have the financial capability of doing it, and everything that just absorbed my whole essence of life was pulled out of me. So it's not just your medical, because I can't get healthy if my mental goes away.
Well, when we talk about medical care, I think we're also including mental health care because we
Yeah, but
have
it's
one
not,
life.
but it's not
But you're also
covering
speaking-
the coverage of what you've got to do as a
Right,
parent
but you're
to
also
cover.
speaking to a system that is unfair.
Right.
And that's really what we're talking about as well, not just the healthcare system, but the larger system that keeps people down, that makes it so that one misstep, you get COVID, you get sick, you lose your job, you can't pay your bills, you lose your apartment, you lose your kids.
You lose your health care,
It's
you lose
unfair.
everything. It's just,
And-
it's a
and
domino.
that's going to contribute to mental health issues. So obviously, it's one thing after another, it's a domino effect that is very unjust for people, while other people are getting very rich.
Thank you so much for sharing that. Kent, the story is heartbreaking, and I think it just goes to prove that, you have to make sure that you're not alone, and none of us are alone in this. And if one thing I've taken from this gathering is inspiration that I don't feel so alone anymore, and I hope you feel the same.